Good evening, everyone. My name is Dr. Firoza Godrej, and I'm a board member of the Asia Society India Center. I'm delighted to see members, patrons, and friends from across the world join us here this evening. For those of you who are joining us for the first time, the Asia Society is a leading education organization dedicated to building awareness about policy, business, education, and arts from across Asia and the globe. Throughout the 13 global centers that we have of Asia, Europe, and the US, we stay committed to sharing contemporary studies, highlighting emerging trends, and spotlighting innovative solutions with a view to deepen understanding and engage between Asia and the rest of the world. The COVID-19 pandemic has significantly altered our day-to-day functioning, stretched our national lockdowns, restricted access to public spaces, and working from home has become the new normal. Unfortunately, this indoor confinement has resulted in the emergence of a shadow pandemic. Through a three-part series, we hope to understand the impact of COVID-19 on the mental well-being of three specific vulnerable groups. We have been through our first session, which deals extensively with our children. The second session was the women in our communities. And today, we're going to try to understand through three distinguished speakers' views the effect on our elders. Our session this evening, which is the last one in this series, we'll discuss how the pandemic has been impacting the elderly, especially individuals living with comorbidities. While the physical health of this group has been clearly endangered by the pandemic, several studies and evidences are showing how the pandemic has affected the mental well-being as well. Increased frequency of mental health risks among this age group, in addition to challenges in accessing regular health screenings, are some pertinent issues. How should the elderly cope with pandemic-induced stress and anxiety? What measures can support easy adoption and usage of telemedicine and tech-based platforms? How can we build support systems for some of these elders who are suffering from the loss of loved ones and impact of confinements driven by social isolation and fear? We have the honor of hosting a distinguished panel to discuss today's subject. Please allow me to introduce our esteemed speakers. Thank you so much, Dr. Radha Murthy, for joining us this evening. Dr. Radha Murthy is the co-founder and managing trustee at the Nightingale's Medical Trust. She also serves as president at the Alzheimer's and Related Disorders Society of India, Bangalore chapter. Thank you so much. I greatly appreciate and thank Dr. Sridhar Vaitheswaran for finding the time to join us here this evening. Welcome, Dr. Sridhar. Dr. Sridhar is an MD, MRCP psychiatry, is the assistant director and consultant psychiatrist, dementia care at the Schizophrenia Research Foundation, India, popularly known as SCARF in Chennai. Thank you for joining us. And I should say good morning, Dr. Ipsit Vahia, for joining us this evening in India. And it gives me great pleasure to introduce Dr. Vahia. He's a geriatric psychiatrist and clinician and a researcher. He is the medical director of the Geriatric Psychiatry Outpatient Services Department at McLean Hospital and the McLean Institute of Technology in Psychiatry in the US. Our moderator this evening, and thank you, Pragya, for doing this, is Pragya Lodha, who is a consulting psychologist based in Mumbai and works with 8 national and international organizations in different capacities. She is the program director of the Minds Foundation, consulting psychologist for NGOs, and a mentor for One Future Collective. Thank you all and welcome everyone. We would also like to express our gratitude to the outreach partners for this program. The Harvard T.H. Chan School of Public Health, India Research Center, and the Lakshmi Mittal and Family South Asia Initiative at Harvard University. A bit of housekeeping before we proceed. All those who are joining us on Zoom, please leave your questions in the Q&A box and not the chat box. For our audiences on Facebook, please drop them in the comments section. I would now like to invite Pragya to commence the discussion. Thank you very, very much, all panelists. Thank you.
Thank you so much, Dr. Godrej, for wonderfully opening today's panel. Before we start, I think I would like to express my heartfelt gratitude to Asia Society for arranging these much needed conversations in the times of pandemic, where we can have one of our most intellectual speakers and practitioners share their knowledge and experience to enhance mental health care and overall healthcare system in our country and globally, of course. Personally, I think I also want to take a quick moment to just share with you all that I am absolutely excited, delighted, and honored to be moderating such an esteemed panel. I'm quite a junior to each of my panelists today, and I'm just looking forward to an engaging panel for today with all our three panelists. So I think without much time, I would just like to briefly touch upon the issue of geriatric mental health care. Addressing geriatric mental health care has not received the attention and the highlight that it deserves. Especially during COVID-19, we all have come across a significant pitfall, which is the bias of ageism, where people are just excluded from receiving healthcare intervention and care just because they are old. Not to miss, but statistics tell us that almost 50% of the COVID-19 casualties have been our elderly. And it's time that the geriatric narrative gains the light that it deserves and needs as well. Anecdotal and research evidence both tell us that our elderly have been severely and clinically impacted by the COVID-19 pandemic, and more so those people who have comorbidities, both medical as well as psychiatric. I think one important aspect of geriatric mental health care that is now being touched upon for quite some time is that of active aging. And I would like to invite Dr. Radha Murthy to speak about active aging while addressing the institutional care challenges and management of geriatric mental health care through the work that she has done at the foundation during the pandemic. Dr. Murthy.
Good evening to all of you. It's a great pleasure. And I would like to thank the Asia Society for this. And also a great meeting with the other two panelists. So we all know that COVID has created a lot of challenges, especially health-wise, emotionally, psychologically, physically, as well as economically. Now, part of it when I am talking now is like, what are the challenges we faced looking after people with during the COVID times? And also active aging would be part of my presentation. So can you go to the next slide, please? Okay. So these are the services which we offer. One is the helpline services, the active aging and enrichment centers, dementia daycare services, as well as residential care for dementia. So this is a sort of a comprehensive care for people who have the problems with dementia. Next. Now, what were the challenges that we faced during the COVID? I don't have to elaborate because all of you know what an impact it has had on mental health. When you see the psychosocial issues, there was immense fear, especially in our institutional care as well as the people who we were looking at in the the daycare centers, as well as people at homes. So the fear was because of the unknown. They did not know what struck them, so they did not have any knowledge about it, which led to loneliness, depression, obsessive behavior. Every time they used to call up and ask whether, even if they have a sore throat or a cough, whether it was COVID. So that was another thing which we noticed. And they were always seeking for support. Paranoia, yes, to some extent. Anxiety as to whether they would get help or not help, and about the disease. Hoarding, this was what was noticed everywhere, is that people started keeping even oxygen concentrators at home, trying to keep all the masks, taking all the thing. So that was another hoarding, thinking that they would fall short of treatment. And last of all is call for continuity of services. And there was a panic because of not getting hospital beds. There was even more of anxiety and fear. So if you see the active aging program, before I go into the active aging program, what was the modalities, the aim and the effect? This whole active aging was based on the Thinking Fit program of UK, which we adopted to the Indian society. So the modalities were like, you assess them, you know their physical activity, you know their social engagement, and what was the aim? To reduce the risk for getting into dementia. You cannot prevent it, but at least reduce the risk for dementia, management of cardiovascular conditions, and promote healthy aging. And what was the effect? So there was an improvement in the physical fitness, cardiovascular health, and better quality of life. Next one. Okay. So this was, offline program which was running well, but due to COVID, what had happened is we had to make some changes to come onto the online active aging program. Now this was quite innovative. It was tried because we are very, it was very difficult for the senior citizens to access online because the difficulty. But the first thing what we did is to try to familiarize them with Zoom. So this was one part of it. And few sessions we had to handhold them, and we had to involve the family members, is because of the help of either getting into the Zoom or having some hitches. So we had to involve the family members too. Now we had also have normal people as well as people with dementia which were doing the active aging, and then modifying the sessions, because offline we had different exercises, and then we had to modify the session so that it would be easier to do it online. The best thing was to use the household items, which like bottles, towels, because we are not able to access, everybody cannot afford to have the other things. And grandkids also got involved, is because when we used to have some music or dance program, the children used to dance with them as well as help them with the sessions. Next, please. Yeah. So what was next is, I have finished the challenges and how it is. So what was the other thing in this daycare and the memory clinic? What are the challenges what we faced? Now the daycare, where there was a need for the daycare is because they lost the support of coming into the daycare. The burden of the caregiver increased, and they could not follow the precautions. Also, the behavioral disorder became a little more. I think the other side part of it is not able to be seen. The other part. No, it's okay. It's okay. Next, please. So, involving now you can see the photograph of the online services. Family members had to facilitate the daycare sessions. We had to, especially with people with dementia, it was very, very difficult to push them to get into a routine. So how did we have to do is to first educate a little bit the family members and see that the family members also had to facilitate the daycare sessions, colorful presentations, so that to draw the attention of the clients, adopting activities to suit the mode of delivery, because all the activities cannot be done, the active aging thing, all of them, like active aging content consists of physical exercises, cognitive exercises, as well as socialization. So all these had to be also tailor-made for people with dementia as well as for normal people. Clients slowly started. We were very happy that people with dementia started slowly getting into this mode. And this brought into a lot of bonding as well as understanding of how to look after people with dementia at home. Next, please. So I was just talking about the DEM clinic. Now, where was the need for DEM clinics? See, these are the services what people were looking for. India's first virtual screening platform. People could not come offline to the memory clinics due to COVID. So we had to make some sort of an adjustment as to how to go on with the online memory screening. Telehealth enabled dementia care model so that we could make it accessible, reduce the gap between the need and the services. And what we did here is you screen the patient, allow them, once the screening is done, many of them refuse to come to the offline because normal people also could access this with small memory issues. And then in case there is a sort of a problem, we could connect them with the psychiatrist. The psychiatrist in turn would do would give the prescriptions. And also we have also seen to it that the care plans are drawn and there is a comprehensive continuum of care because of the online memory screening. So DEM clinic has become a sort of a, especially during this time, has been a little bit of more of a, more acceptable now. So we are finding it really easy to continue with this service. Next, please. Now, when it comes to residential services, this is what I was trying to tell is, this is all the impact of COVID, what had happened. That they were highly susceptible and we had difficulty during the first, I think the first wave as well as the second wave. The second wave, we were more competent to carry on the work, but the first wave took us by surprise. So the residents were highly susceptible to comorbidities. Secondly is they could not, the inability of the people to talk about their problems. And then even to give the precautionary measures, we were not able to ask them to wear the masks, increasing the cost of care. With the cost of care went up is because the caregivers were given more where to wear the washing, using more of a sanitization. So this was the increase the cost of care also. Staff related issues were there because they were worried about their health as well as their family and the fear of COVID. And hospitals were not well adapted to looking after people with dementia. So even the guidance we could not get it from the government is because my pressure with the government was like, why don't you give us a proper way of looking after the elders, because that was not their priority and they were not ready. I mean, they are also, the first wave was difficult. We had to run around asking for protocols and how to engage them. So we had to make our own changes. So the next one. Yeah. So these are the care homes, different care homes that we have. We have about 4 care homes for dementia. The largest one is the Nightingale Center for Aging and Alzheimer's, which is a 98-bedded facility. The other one is which is in Kolar, which is through telemedicine, which we look after. The other one is only for women is this Nightingale's Tanya Matthias Care Center. And you will see the last is Sandhya Shurakta, where you have the 70-bedded facility for women again. For less marginalized, that's what is this Sandhya Suraksha. So altogether, we had to look after about 208 patients. Now, when it comes to this NCA, what I call this the Nightingale Center for Elderly, we had short-term, long-term, multi-speciality team, non-pharmacological intervention, and a hub for satellite centers, because which I said telemedicine through Kolar. The next, please. Now, let me talk about the COVID impact. Now, what happened about all this? Okay, things were running very well till COVID struck us. So what was the first impression of the whole thing? Is panic, not understanding the whole thing. So as soon as there was an announcement of lockdown, we were in a shock. Everybody was in fear, anxiety, uncertainty, both as well as the caregivers, as well as the patients. Staff could not come to the center, and availability of mask and all slowly. I mean, in the beginning it was okay, but as the people started hoarding, there was paucity, or there was a shortage of thermometers, pulse oximeters, and there was no exact information about this whole COVID-19. Now, how did we, despite these challenges, we still felt that we had to keep them at the facility, is because the families were not capable of looking after them, and we said so we gave them a support and said this, we'll try this sort of managing them at our center itself. Now we formed the crisis management committee to monitor the situation, and then we had some protocols and guidelines developed. Major decisions were taken with respect to the infrastructure. We had to make a lot of modifications. We had to train the staff. We had to stop the visitors. The government officials, we had literally asked them to come to inspect, to guide us. But it took a lot of pressure on from our side to make the government understand that these were a special people whom we had to look after, because nobody understood dementia. So it was a lot of pressure from us to push the government. All protocols and preventive measures implemented without keeping the quality of care intact. And at the same time, we kept the families in touch constantly about this period. Next. Now, quickly, you can just see the same thing which I am repeating. This is the formation of the Crisis Management Committee and drafting protocols and SOPs. We had to do this is because we had to learn it ourselves, how to do it. And we invited the BBMP to see whether we did fit into all the safety measures. So they did agree, and they gave us some sort of suggestions. So this is the protocol displayed first, so that it was adhered strictly. The next one. So the access control, everything we had to close, direct access to the whole thing, we closed it so that the administrative staff remains away from the block where the people were with dementia. The emergency entrance at the rear side of the building was opened so that it could be a 2-layer security cover. Visitors and admin staff were only restricted there. They were not allowed to come and mix with the administrative staff. Temperatures regularly as the protocol is already there, temperature checked and hygiene performed for all visitors coming in. Next. Close surveillance of the thing is thermal checking up. You can see that kitchen staff were trained, the janitors were trained, the second level of checking was done, and then fingerprints, instead of fingerprints, but we even made it into the facial recognition in the biometric. Initially, we did allow the family to come inside, but later we could not because the numbers increased. The sad part of is we could not send them to the hospitals is because the hospitals did not know how to handle the patients with dementia. So it was so we lost a few patients, and then we decided that we have to look after them here with our own protocols. So initially, though the family was very, very anxious, we did not allow them to enter. From August, families permitted to visit this August we allowed them to enter. Visitor lounge to create it so that it is away from this place, and you can see how it was designed to keep a barrier to prevent the infection. Next one. The same goes with the residents. Every day, as the same protocol of temperature checking, SPOT checking, and vaccinated for influenza. And you can see COVID test done. If the symptoms persisted for more than 3 days, then immunity booster drinks on a daily basis. Next. Now, families which could not come, we had to have a virtual. You can see how they were interacting with the patients and the families, because they did miss the people with dementia, really miss the families, and they were very, very concerned. And this helped them to at least have a connect with the families. The families were happy with this sort of arrangement. Here again, we had to make this thing is like the number of caregivers were reduced because transportation was not available. People had to stay back in the center itself. So we had to reduce the number of caregivers. They were given accommodation here itself, free food, risk allowance, and then regular distressing activities conducted for all staff. Again, I told you we had to make the most thing is into the infrastructure, because we had to have an observation unit created. And why I'm talking so much about this is many deaths were happened in care homes all over the world. The most of the dementia patients suffered, and they did have this particular. So this protocol and thing has become very, very important to keep them safe. This created an observation unit for the residents for the hospitalization. They observed for 10 to 14 days on the physician's advice. And then we had also support of 1:1 caregiver to look after them. And also is before we took them back from the observation unit back to the unit, we did a COVID test again. So these were the important precautions that we took. Next one. Then we had the step-down ward, wherein the people were shifted to the step-down ward for special attention. And if we suspected, even with little fever or cough, we kept them away if it lasts for more than 3 days. And in case of, if we suspected that they had something, we used to inform the COVID command center of the government. Fumigation of the ward was done and the residents shifted. That we did it in the first phase. And once we lost it with second phase, we completely managed them at our own center. This is the quarantine for the staff itself, because some of them fell sick. So we had to have a quarantine facility for the staff too. This became very, very important is because the cleaning was most important and how to keep them clean. So training on infection, prevention and control for janitors was a must. And that's how it was. The regular training was happening by the nursing supervisor. Again, I don't have to tell you so much about this thing. In the beginning, we had to frequently do it, clean the mopping the floor. Vehicles were disinfected every trip. Switches were looked after. So this was a continuous hygiene and disinfection practice, cleaning the washing the hand, wearing the mask. All these things were part of the practice. Staff training, regular staff training, so that they keep up the same tempo, and also to see that they do not have the burnout. Now let me go to the outreach and the support system is, you can go to the next one. How did we manage this in the old age homes? Some of them we were visiting old age homes to see whether we could improve their quality and to understand. So we did go there and train them as to how to look after them, people with COVID. How do you know how to do the protocols to be followed during COVID, and train them in all the COVID care precautions. So this was the other COVID care management in old age homes. This was the newly introduced one. Next one. Now, when it comes to helpline, the helpline received a lot of calls during this thing, anxiety ridden by the senior citizens. It was, you could see the numbers. If you could see the numbers, the service introduced, they contain like, you can see the number of, I think you can see one guidance and support nearly about 145 people, and we resolved 141. You can see the numbers there. And people asking for pensions. So it was not only health, but it was also the economic issues which were there, subsidies. And we enlisted the volunteers, and a lot of counseling also happened through this helpline service of 1090. So these were the outreach programs. Next. So going forward, what we carried out is that the care homes and the what do you call it, daycare centers, we have to see the best practices to be documented. The daycare and active aging to be standardized. Minimum standards for care homes, keeping pandemic in mind, and how to keep the cost lower. It was very, very expensive for everybody. So how to keep the cost of care lower, and protocols for future. I mean, we have to be prepared for the future. We do not know whether how long it will extend, but still we have to have this protocol. Research on elder friendly technologies, which I think we will be speaking about it later. Focus on for psychosocial well-being, training of medical community. Many of them are not aware of it, so probably that. And policy changes, I think other doctor mentioned, policy changes and adaptation. So next one. So with this, I conclude this, the management of COVID and mental well-being. So thank you.
Thank you so much, Dr. Murthy. I think that's some commendable work being done at the organization, right from, I think, taking care of not just the services being provided, but also taking care of the training and very careful insight into the holistic staff, the trainers, the janitors, as well as the visitors. I think quickly, just keeping one thing in mind and taking a key takeaway from your presentation. I take note that to keep our elderly active, healthy, and independent, we do need active aging programs, and daycare centers become a very meaningful way of engaging our elderly with, active aging. But I think considering the impact and the negative impact of COVID-19, which I think in some balanced way has had its pros and cons both, I want to quickly ask you that we've already had unmet needs, to especially cover daycare centers and memory clinics, especially in countries like ours when it comes to geriatric mental health care. On the basis of the experience and the work that you've had, along the pandemic, how do you really foresee the future of daycare centers and especially memory clinics also, which have been long in conversation in our country especially?
Yeah. Memory clinics are a great need. And if you say daycare centers, yes, for the time being, it is not an offline solution, but you could go on to the online solutions, which I think could be the future. I think we have technology-based things should be more promoted. I would say, like, what is that we really require is that memory clinics need a multidisciplinary approach of psychiatrists, psychologists. So, but if you see the dearth of the specialist, you don't have enough of specialists to. There is about 2 people in about 1 lakh. So it's very difficult to about the how to screen the person. And if you go to see about the training is very, very inadequate, especially for people, physiotherapists, the OT people, that is the occupational therapist. So I think in future training would play a great part in for this memory screening, also memory clinics. Also, you notice that about 10% of people have been diagnosed, the 90% have not been diagnosed. So the accessibility of a memory clinic is a great need. Thirdly, the primary physicians are not trained well to understand dementia, and probably more of awareness and training need to be, or sensitization to be done there. And online clinic, I think, could be an answer now at this time. So online screening does improve the screening part of it. So I think this is my take of memory clinics today.
Right. Thank you so much, Dr. Murthy. I think it indeed is incredible to see the potential that digital technology may have in geriatric mental health care as well. And like, I think how we saw that maybe the success of DEM clinics can actually be scaled up to a national level and for the global level to see how it can actually help bridge the existing huge gap that we have when it comes to dementia care. Thank you so much, Dr. Murthy, for your valuable input.
Thank you.
Thank you. I would now like to invite Dr. Sridhar to take this panel ahead. Sir will be sharing with us details about his work at SCARF, especially also touching a little bit upon dementia care again, but based on his study. Also, I think an inclusive input on caregivers, the impact of caregivers of dementia during COVID. And I think especially the growing need of telemedicine, especially in dementia care. Dr. Sridhar, please take over.
Thank you very much, Pragya, and I must thank the Asia Society for having me here. And it's wonderful to be with this elite panel. And thanks, Dr. Radha Murthy. It was wonderful to hear about your work, and it's such a fantastic, initiative that you're doing, and it's great to learn from your experience. I think it's fantastic. So what I hope to do today, I don't have a presentation, but what I hope to do today is to give you an overview of how COVID has affected our society overall, and particularly focusing on the geriatric mental health and how the services have been impacted. So as you can imagine, COVID has affected everyone, and particularly I would like to look at from the perspective of a service provider, and also look at it from the perspective of service users and how things have been difficult, now how we have adapted to the situation. So if you look at from the perspective of service users first, we did a study last year and we published it, and looking at the experiences and needs of caregivers of persons with dementia, and we kind of had highlighted a few issues, and I thought we could kind of just focus a little bit on if you want to look at the impact on service users. So we have two things. One is the impact of COVID on people with pre-existing mental illness. And the second one is the impact of COVID on people who have a new onset of mental illnesses because of COVID. So that's how we can kind of look at it broadly. And if you look at pre-existing mental illnesses, the main issue, as Dr. Radha Murthy has highlighted, is access to services. At the time of the initial lockdown and the fear of COVID and everything, people couldn't access services for their mental illness, access services for their comorbid physical conditions. So if someone has diabetes or they have an eye problem, they couldn't go and visit the appropriate specialists, appropriate facilities, and that was a major issue. And of course, COVID, as you know, brought about a lot of changes in routines and activities, and that became a big problem, particularly for people with dementia, where they couldn't go to day centers, they couldn't have visitors, they couldn't have their children come and visit them, or meet friends, go out to temples or to churches and usual things. And that resulted in worsening of the behavioral and psychological symptoms in dementia, wherein we had lots of anecdotes wherein persons with dementia were restricted at home. And at the same time, there were grandchildren who were attending online classes, and then adult children having to, have working from home, and the person with dementia being restricted in the house and disrupting the work of everyone. And that resulted in a lot of issues and challenges for families. And then, of course, the biggest problem that some of the families faced was admitting someone with dementia or other mental illnesses with COVID into a hospital. Now, I know some of them needed to go into the hospital, but as a policy in Chennai, the Corporation of Chennai wanted to admit everyone who is above the age of 60 if they developed COVID. At least initially, when there were beds available, they needed to go into the hospital. And that was a big problem because the hospitals weren't managing people with dementia very well. And we had to actually have a case wherein a gentleman with very advanced dementia who was actually receiving palliative care developed COVID. And unfortunately, the family was forced to admit him into a general hospital where things deteriorated very rapidly. And that kind of flexible approach to policy and need for specialist facilities to manage people with dementia and coexisting mental illnesses who develop COVID was the biggest need that was brought forward during this time. And when you look at the new onset of mental health problems, I think Dr. Radha Murthy has already highlighted, anxiety disorders were quite common. Depression was another major issue that we actually saw in our clinics. And then, of course, we had a new onset of psychotic illnesses, people with, pre-existing illnesses, but then they remitted. and then the symptoms relapsed once again. And so those were some of the issues that came about. So when you look at how the services adapted to all these problems, and of course, during the initial lockdown, doctors were allowed, the doctors and healthcare services were open. We could travel to the society, to the hospitals and see patients. But of course, patients couldn't come because of the lockdown and the lack of public transport services. So that, and subsequently, we started doing a lot of telemedicine. And in fact, more than 50% of our caseload are currently using telemedicine. That's something which I would like to highlight, is that telemedicine has a huge role to play in managing the crisis, and also going forward in the future when the pandemic becomes an endemic and then kind of subsides. So what I would like to say is that telemedicine cannot replace in-person consultation, but telemedicine can be a fantastic supplement to in-person consultations. So that's something which we have found quite useful now, in that about 50% of our initial assessments are done through telemedicine. And then for some of them, we will be unable to complete the assessments because of various reasons, and they need to be seen in person. And then when they come in person, we complete the rest of the assessments, form a diagnosis, communicate that, start a treatment plan, and then the reviews, they can do it online. So they have the option of doing it online. So almost 50% of our review appointments are now conducted online, and that decreases the time that they need to spend coming to the clinic or being in the clinic. And also many of the interventions that we offer, particularly looking at interventions like cognitive stimulation therapy, or even some of the interventions for caregivers like START, which is strategies for relatives of people with dementia, which we are providing online. And that has taken off really well. And I feel in the future, the online mode of delivery can go hand in hand with in-person delivery, and that will actually help a lot of families. In fact, some of our caregivers have said that doing it online has reduced the need to come to the center, the transportation issues. People, particularly for people coming from faraway places, they feel that it'll be easier to access these services. In fact, based in Chennai, we are providing services for people from other parts of India. And also, in fact, there was a gentleman from Bangladesh who actually was able to access some of our services. So having telemedicine does open up a lot of options and definitely helps in reducing the treatment gap, which Dr. Radha highlighted. 90% of people with dementia do not get a diagnosis, and definitely, or any interventions for that matter. So definitely having telemedicine can help in bridging this particular gap. Now, in terms of how the caregivers adapted and managed the whole situation, is that we used to have a very active caregiver support group, which met every month. And of course, we moderate those sessions. We have a specialist going in to talk about specific issues which the caregivers want to talk about, like nutrition or skin care or bladder care and things like that. But eventually, because of COVID, these sessions had to stop. And many caregivers actually started forming WhatsApp groups, and they interact quite actively in these WhatsApp groups. And then they started meeting quite regularly. In fact, they are meeting more frequently now. They meet once in 2 weeks by Zoom and by Teams. And that's really a fantastic opportunity for the caregivers to network. In fact, has grown to such a big extent. I don't think it would have grown if COVID wasn't here. So in a way, it has facilitated the growth of the support groups for caregivers of persons with dementia, at least in Chennai. But in the future, I see when we are able to open up and bring people together, having these technology-based solutions can augment the services that we provide. So with that, I will stop, but I'll be more than happy to answer any questions that you may have. Thank you.
Thank you so much, Dr. Sridhar. I think that's yet some more laudable work happening in the space of dementia care. And I think it's very interesting, and maybe for the lack of a specific word, it sounds like telemedicine has actually revolutionized dementia care to some aspect, also giving us a lot more hope, again, like how we were speaking, to bridge this treatment gap, which has been ever existing. I think it's also very interesting to note the work that staff has done to especially attend to the needs of caregivers, because I think dementia care is incomplete without addressing the needs and to provide support to caregivers of persons with dementia as well. However, sir, I think taking note of the potential of telemedicine, especially in dementia care, what do you think, as part of your experience, how equipped are we, and do we have certain loopholes, especially anything that policymakers or maybe in terms of guidelines that can be done better in the present, future, both times?
Yeah, exactly. Thank you. Thank you very much for that question. Yes, it is a big issue. The digital divide is huge in our country, even though we say telemedicine is important and it's a fantastic opportunity to get people in. There's a huge digital divide. I think one is lack of access to technology. That's one of the basic problems, particularly people from low socioeconomic stratum of a society, wherein they don't have access to technology. They don't have a smartphone or a laptop or a tablet computer or internet connection, and that becomes a huge problem, or a good internet connection, I must say, which is a problem for people even living in smaller towns. They have this particular issue of good internet connectivity, which is a big issue. So it is something which I think as a nation and as a we need to evolve, and I think that's something which needs to come up. The other biggest challenge is technophobia. That's something which I find in many elderly and even otherwise. We have a lot of anecdotes wherein families are resistant to using technology to help see their relative with dementia, or use some of the interventions that we suggest that might be useful for them, because they just scared, or they feel that it will not work. There's a lot of resistance which kind of comes up right when you start talking about it. But then slowly, I mean, we try to work with them gradually and introduce the concept of how it can be useful. This is better than having nothing else, because at this point in time, our day centers are not open. This is the only option that you have, and that kind of slowly changes their perspective. So that is something which is an issue. So digital divide, due to various reasons, socioeconomic, lack of access, and lack of awareness about the use of technology. Those are the things that the policy should address. Regarding the use of telemedicine, the legal issues and the problems or potential, some of the questions that many of us had initially was how ethical and how legal is it to use telemedicine? So is a telemedicine consultation as, legally, are we legally bound? So if there is something which happens to the patient at the end of telemedicine, we prescribe a medication, how legally accountable are we to that? So I think the national digital policy, I think that's led by NIMHANS. I think they have done a great job and coming up with national recommendations for telepsychiatry, and that's really helped us a great deal. But that's still a document it's evolving as we speak. And I think Niti Aayog is also involved in this work. I think there is a lot of work that needs to go into it. And some of the other biggest challenges we have is issuing online prescriptions, and how these prescriptions are being refilled, how they are being used, and which drugs we could prescribe, which drugs we couldn't prescribe. In fact, according to the policy, the national policy that we have, many of the drugs that we use for dementia cannot be prescribed online. So there is a problem there, but I hope that will all be resolved in the near future.
Thank you so much, sir. I think so important for us to be aware of, what kind of services are also available amidst the time of the pandemic. And I think listening to you, it does sound like digital technology is yet to grow, I think, in terms of service policy provision. And I think to become a lot more holistic and comprehensive, especially I think even when we look at not just mild cognitive impairment, but also the more moderate to severe category and how they can be attended to through digital means. And I think also like how you were mentioning, some time before, that if India is to hit a number of 10 million people with dementia, possibly having dementia till 2040, I hope the government does take note and take immediate action. Thank you so much, Dr. Sridhar, for your valuable insights and meaningful work that you have shared with us. And I think just in continuation, I would say that the chronic diseases like dementia and Alzheimer's are not just challenging, particularly because of the associated mortality that brings in and is brought by the disease, but it's also because the COVID-19 pandemic has also, I think, introduced a lot more vulnerability to people with cognitive impairments. And our last panelist, Dr. Vahia, interestingly, is going to share a slightly positive and a brighter picture amidst the entire challenge that we've had in dementia care. So, Dr. Vahia, I invite you to take over from here.
Sure. Thank you for that, Pragya. And my thanks to Doctors Murthy and Vaitheswaran for their really outstanding work and excellent points raised today. So I'll start by stating the obvious. I work at McLean Hospital in Boston and at Harvard Medical School. So decidedly, it's a very different day-to-day reality. And what I'm going to focus on today is lessons that we've learned through global research and through aggregating reports from individual countries around what seems to be going on more broadly with older adults, including but not restricted to those with dementia. So I'll start by a story. I don't have slides by design because I want to keep this more open-ended and discussion-based. But I'll start with a story from one of my own patients. This is an 84-year-old woman in relatively good physical health who I've been seeing for years, about once every 2 months. She does not have dementia, but she has both depression and anxiety that are relatively well controlled. When the pandemic hit, she was someone that had a smartphone, did not know how to use Zoom. She is an intelligent woman with resources, so she was able to get someone to teach her Zoom. And I met her about a month into our lockdown in Boston when I was concerned because this is a woman that lives alone and is able to live alone overall, but now she was cut off from her family and a lot of resources. And I asked her, "How are you doing?" And she smiled and she said, "You might enjoy knowing this, but I actually had the last respiratory virus pandemic illness, which was the Asian flu of 1959. So she's like, "I've actually seen this before," which fascinated me because I think sometimes we take for granted the kind of longitudinal perspective that older adults have that we may forget about. But her next question is what stayed with me. She says, "I'm fine. The more important question is, how are you?" And that took me back. And I'm like, "I'm okay. Why do you ask?" And she's like, "Because think about it, Doc. I've lived my life. I'm 82. I could die tomorrow and it would be okay. I'm not really that nervous. I live by myself. I still talk to my family thanks to Zoom. But my day-to-day routine was a relatively simple one. I would go out for walks. I would spend some time doing educational stuff. I would exercise. I read. I'm still able to do all of that. I also don't have to worry about losing my job. I don't have to worry about what my financial future is going to look like. And I sure as hell don't have to worry about what my kids are going to do in school. So I appreciate your asking how I am, but I'm really more worried about you because you have all of those things. That encounter has stayed with me. And what's more interesting is that shortly after this, I experienced one of the great privileges of my professional career. I was appointed as the COVID-19 section editor for the American Journal of Geriatric Psychiatry. What this has involved is overseeing the process of receiving, evaluating, and publishing global science around COVID-19 and mental health, some of which we compiled into an editorial for JAMA that's in the chat box link. But we've learned an important lesson or two from studying how older adults have done in the pandemic. The biggest one is that while everything that Dr. Murthy and Dr. Vaitheswaran talked about is real, as a whole, older adults have handled the pandemic better than just about anybody, period. Rates of mental health distress have gone up, but they've gone up by the least of any other demographic. So to translate that, for someone in the 18 to 25 age group, they're 6 times more likely to have depression, anxiety, psychosis, substance abuse, suicidal ideation, post-traumatic stress disorder, 6 times more likely than someone that's 65 or older. Older adults have experienced isolation, but there is a critical difference between isolation and loneliness. Isolation is the physical act of being cut off from your social network. Loneliness is the more subjective experience of feeling cut off. Many older adults have been isolated, but have not necessarily felt lonely. There's been a self-sufficiency to it. And we're studying why this is, because what's also interesting is that this is not one study, it's not one country. As of this morning, comparable findings have been reported from North and South America, Asia, a small study in Africa, multiple studies in Europe, and a couple of studies in the Australia, New Zealand region. So all continents, all study formats, a number of different ways of measuring these mental health outcomes, right? You never see this in science. You never see so much consistency across so many studies about the same question. So it's real, it's global, and we're probably not paying enough attention to why this is, that there is a silver lining here, and a paradox. Why is the age group that is most at risk for death, most at risk for isolation, the most physically impaired with comorbidities, the most restricted in terms of their functioning, why is this group handling the mental health stressors of the pandemic better than anyone else? I think the answer is multifactorial. Some of it is qualities that come with age, experience, emotional equanimity, resilience, wisdom, if you will. Some of it is what my patient alluded to. Most older adults have a simpler life. They're juggling fewer things in the air. They're taking care of fewer people. So there's practical issues that just reduce the stress load. But there are lessons to be learned as well. Interestingly, the biggest predictor of isolation turning into loneliness is not the extent of the isolation or the mental health piece or even the physical health piece. It's more anxiety about catching the pandemic, catching COVID-19, or financial worries, or physical restrictions and physical inactivity. In other words, not exercising. And I think when you translate these global findings to the clinical level, the biggest thing we learn is that when it comes to older adults, one size does not fit all. If you study and talk and treat one older adult, that's all you've done, treat one older adult, because the next one could be completely different. This matters. When someone makes it to the 60s or 70s or 80s, the person that they are at that age, we know from newer studies of lifespan understanding of aging that the person you are in your 70s and the 80s is the end product of a number of experiences, circumstances, even genetic and biological factors that play out over time, diet, habits, vascular damage in the brain, vascular damage to the body, things like that. And because I think we would agree that everyone has a distinct life, it means they are a distinct person with different abilities to withstand different stressors. This matters. I think we can recommend general approaches, technology and digital health being a big one, but understanding each individual is really going to be the key going forward, because like I said, you can make general recommendations, but one size does not fit all. Insofar as technology goes, I think Drs. Murthy and Vaitheswaran have alluded to the bigger pieces about telemedicine and digitizing care. I'm especially thankful to Dr. Vaitheswaran for talking about digital disparities and inequities. Because from where we sit, our job is to make sure that all care and resources are equitably distributed. That you may go to bringing 90% of people on board with digital health. But what about those 10%? Because those 10% pound for pound are likely to be poorer, less educated, less access to technology, maybe more rural and isolated. In other words, these are the people that are already the neediest. And are we going to make things much worse for them by enhancing digitization? Dr. Godrej started out this discussion alluding to policy. And I think this is an important one because we know that so much upheaval comes from disparity. And I think this needs to be addressed head on. NIMHANS is involved in drafting a technology policy for India. I've communicated with some of the personnel involved with that. And I think this is the point we make. The second point is training. Again, as we've heard, technophobia is real, reluctance is real. But we also know that with personalized support and educating older adults about not the technology, but what they're going to get out of it is the key. In our populations, people switched to Zoom easily enough, but it was not because they wanted to keep their doctor's appointments. It's because their grandchildren were on Zoom and their religious services were on Zoom and their social clubs were on Zoom. So when Zoom was the thing that allowed them to have an approximation of their life, it offered value. And so they were willing to learn it. Before the pandemic, I could have spent all my time trying to teach my grandmother how to use Zoom and she would not have learned it. Now, in my grandmother's case, she did in fact learn how to do video communication. It was not because it was good for her. It was because it was the thing that let her participate in her grandson's wedding in America without having to actually travel. That lesson has stayed with me as well. Value proposition matters when you're trying to digitize the lives of older adults. We know that they do better when they communicate well. I'm going to pause now to get into more discussion, but I'll reiterate my key points. Older adults have withstood the pandemic better because of an ability to have resilience, to see the big picture and lean on experience, partly because they have simpler lives, and that's something for us to think about. And technology helps, but it has to be done right. I'll pause there.
Thank you so much for quickly summarizing that for us, Dr. Vahia. And I think some very important, interesting takeaways from your discussion with us. And it certainly, I think, thickens the silver lining when it comes to geriatric mental health care, where we do have a positive side to look and build upon also, despite all the challenges that we sort of have seen all this while along with during the pandemic. However, I think something that I would, like for you to probably share with us is that something that we have been speaking about, especially as part of dementia care also, is the increased neuropsychiatric risk that we see in our elderly. Would you like to just briefly comment on this question and share with us what you think about the same?
I think there's layers of neuropsychiatric risk. One big finding, and these have been studies that have come out in the last 2 or 3 months. So studies specifically of older adults that have had COVID and recovered from it. I think that bears watching because inherently an older brain is more fragile, less resilient. There's vascular damage. There may even be some neurodegeneration. We know COVID, the virus, is devastating to the nervous system. It can enter the brain through synapses, through blood vessels, or through infecting white blood cells. So it's able to enter the brain in 5 different ways. And once it enters the brain, it can destroy nerve cells, oligodendrocytes, and astrocytes. So just about every type of cell in the brain can be impacted. Even people that don't have neuropsychiatric symptoms still experience some quantum of damage. The worrying finding is that for people that had dementia, the 6 month, for people that had delirium, so no dementia, but had some confusion or loss of sense or smell, we're now seeing data that suggests 6 months after they fully recover, their cognitive function seems to be declining quite acutely. And the rate of depression and anxiety in this specific population, people that were hospitalized with COVID and survived it, the 6-month neuropsychiatric symptom rate can be as high as 85 to 90% in some studies. So this is troubling. Some of my colleagues like Sharon Inouye, who is the world's expert on delirium, have actually predicted that a dementia epidemic may be coming 2 or 3 years down the line. Now, this is a very different question from how older adults are withstanding the pandemic in general. We're talking about people that actually caught the virus. But it sort of goes back to what I said, that one size does not fit all, that an older COVID survivor that had neuropsychiatric symptoms is very different from an older adult that has means, is well resourced, is well supported, and has access to technology. Those two people are going to do very differently in the long term. We as clinicians, we as family members and members of the public that interact with older adults need to remember this.
I think the statistics are quite like goosebumps giving, but I think still as clinicians, as individuals, we all need to just be on the lookout. And I think as we were discussing earlier that, most of the times people step in for care only at a later point. So hopefully, I think if not completely bridging the treatment gap, I hope that, and I think we all hope that digitalization and digital media can at least, expansively increase and accelerate at least the awareness around dementia and just geriatric mental health care in general as well. Which has long, I think, been waiting to get the deserved attention that it does. Thank you so much, Dr. Vahia and all the other panelists. I think I would now like to also, leave some questions for all the three of you, and if we could just, sort of engage as well. And I think one of the questions that comes first is, which was also asked by one of our attendees today, is that you all have shared, I think, a lot of meaningful work and experiences out of everything that you all have done during the pandemic, which has also been, I think, a lot more related to institutional care, maybe policy making, and a lot more from a professional standpoint as well. I would like to ask each one of you to also briefly comment that for our attendees who are a mix of individuals and professionals, what do you think are some key takeaways and messages for individuals, especially as caregivers for dementia and in general geriatric mental health care? Like, how can this gap be met, at least at the individual or the familial level?
I can make a first point.
Sure.
I would say it starts with ask the question. Stigma means sometimes that you make assumptions that someone is doing well because on the face of it, they appear to be doing well. I think if we're going to get into understanding mental health at an individual level, it's a very simple thing. Ask somebody not how they are doing, because the answer to how they are doing or kaise ho is I'm doing fine or main theek hu. The question should be, are you okay or sab theek hai? It's a very subtle difference in how you ask the question. But if you ask somebody whether they're okay, you're assuming that maybe they're not, and you give them an opportunity to tell you. There's cultural elements to this, of course, and I'll defer to my colleagues on the panel to kind of get into that. But there's a lot that can be said about things that we can do, but in terms of how you can make actionable change, it really starts out by asking questions that acknowledge that this is even something on your mind.
Yeah, thanks very much, Dr. Vahia. I think one of the important things that I tell all my caregivers is not to think about it too much, not to worry about it too much when it comes to COVID. I think one of the initial problems was people were hogging news channels. They were constantly watching updates. We're looking at how many cases here and how many cases there and how many deaths, and of course media didn't help. When they were highlighting particularly issues about lack of beds and lack of people queuing up in the crematoriums and things like that, that really brought out a lot of anxiety amongst people. One of the things which I kind of talk about when we speak to the caregivers or even amongst the general public is to say that yes, it is here. And it is important that we acknowledge that we are all anxious. Even I am anxious. I'm worried about myself. I'm worried about my family. But that doesn't mean that it should allow us to be overwhelmed, even though it's easier said. And if you feel that you're not coping, please ask for help. I think that's something, it's a very important message we need to tell everyone. And again, being sensitive that to change. I think if you find that your relative is not coping, if you find that they are not managing their routine life, they are not sleeping very well, they are not eating, you see subtle changes. If you notice that in your family member, please ask for help as early as possible. I think some of the early interventions, supportive interventions, non-pharmacological interventions can go a long way in stemming the problem from becoming worse. And even if it is worse, even if it becomes a full-blown depressive disorder, an anxiety disorder, there are very good treatments which are available and which can actually make a huge difference to these people. Majority of the people, as Dr. Vahia said, majority of them do well. It's a small subset of the population who need help, and they definitely need it, and we need to be sensitive to pick it up and help them. I think that becomes a duty of everyone. I mean, if you're a neighbor and if you have someone who is an elderly person living near you, just keep a lookout for them. Are they keeping all right? Meet them if you can, and ask them if they need any help. I mean, those are the simple things that we can do from our side as an individual.
Coming from the experience, whatever we saw about the caregivers, when the COVID, the first wave was there, many of them just abstained from coming. Many of the caregivers were not wanting to come. And it took a lot of thing to bring them back. And I feel training, whatever we gave, the training helped a lot. And also, as Sridhar pointed out, there was so much of information into them through the media. There was a lot of anxiety. There was a lot of misconceptions about the whole thing. So once the training was on, and as you said, this helped, I think, most of the caregivers. And then also we try to see that the stress, when they were looking after people, how it could be busted. So we had to give a lot of, I think, what you could hand-holding them to overcome this particular caregiving. So I feel once you know about the disease or once this thing, the caregivers are definitely much better lot to handle this whole situation. The other thing what you were trying to say is the senior citizens were, I feel, to my thing is, were less affected rather than the other population, because I think they were able to, as I think Dr. Ipsit already mentioned, is they were more a resilient crowd which could come out of this situation. And I feel that at this time we need more services. How do you create awareness about the services? People are looking out for help, support, services. So I think that has to increase. Most of the problems will be solved, and information, right information which should be given to them. I think these are the things which have to take forward.
Thank you all of you. So I think we sort of highlight on the facts that we begin with, I think, breaking the stigma with a simple conversation, and the how we ask how you are doing really matters. Reading a little bit more into just the simple okays and I'm fine and I'm good, and taking the conversation ahead to also, I think, simply being a lot more observant of our elderly around, which I think also brings me to the fact that one of the most prevalent myths around geriatric mental health and in general geriatric healthcare is that we just assume that things just deteriorate with age. But I think this is, the whole stigma of
Winding
ageism
up.
that also, are prevalent. And I think lastly, as Dr. Murthy was mentioning about that, where caregivers and individuals can also just, come and sort of hold hands with professional trainers and caregivers, and we bridge the gap together. Thank you so much for answering that question, all of you. Another question that I generally had, and I would like if each one of you can share with us out of the experience that you all have had working with the elderly for so many years now, and the unique challenges that you all have in your own capacities overcome in the pandemic times, that what are some key takeaways that we can take away, especially from the COVID-19 impact on geriatric mental health care? How does the future really look like, especially with, I think, digitalization being on the boom with so many things, and we've talked about various aspects of our elderly adapting to the same as well. So anybody who would just like to go ahead and start off?
Really talked about it, I thought. I'll just say the same points, or just reiterate some of the points. I think COVID-19 and the pandemic has given us an opportunity to look at technology as an option to provide services for people who are elderly, and not just elderly. For any condition, any mental illness, and particularly of focuses on geriatric mental health at this point in time. I used to work in telemedicine many years ago in the UK when we were providing support to a remote island called Shetland. Shetland Islands is quite a distance from the mainland UK, and we were providing telemedicine support. And at that time, one of the important barriers to accessing services was that if you have a ready local service available, why would you want to go and use a telemedicine service? And that was one of the problems. And again, the other important barrier was, what is the need for this at this point in time? And that those are some of the questions that came up as people not wanting to use telemedicine. And that was the reason. But then with the lockdown, with the pandemic, and the fear of going to hospitals and all that, now people are open to using telemedicine. And I hope that we catch the tide and go with it and get this done, because that is the only way we can actually that's, I wouldn't say only way, one of the ways in which we can actually cater to the needs of the booming problems that we are facing at this point in time. So used well, used judiciously, I think technology and telemedicine can play a huge role. And if we miss this opportunity, I think another 5 years from now, when the pandemic is gone and people will have very little memory of what happened, I think we'll be back to the usual way of practicing, wherein people have to come in person and there will be a queue, waiting lists, and things like that. If we can, use this judiciously and use it well, I think this gives us a fantastic opportunity to move forward in this region.
I would say that evident gaps in the healthcare services in handling mental health issues. As I said, going forward, probably telemedicine, using of technology would be a great way forward. The other thing is, I also noticed that there is no data available in the COVID care homes or the old age homes. So that could help in taking how to take mental issues forward. And awareness, which is not there about the whole thing, and also increasing the sensitization of how to increase the sensitization of mental issues. So I think this is the way forward for coming as a answer to the problem. I don't know. It may. What do you? I think that says it all.
Right, absolutely, Dr. Murthy. Thank you so much. Dr. Vahia, any comments?
Well, before I answer, I want to go back to what Sridhar said about 5 years from now, when people have forgotten about the pandemic. May we get there. I can't wait. But more concretely, I think a couple of points. I think normalizing the mental health strain of the pandemic is important. not just for older adults, not just for caregivers, for everybody. I think if we could do that, and it's much easier said than done, I think it will turn the temperature down, that some things that used to happen aren't going to happen anymore. They're not going to happen the way they used to happen. They may not happen as well, and that's okay. If there's a lesson that older adults have taught us, it's that if you stick around long enough, you realize that things that feel like the end of the world may not quite be the end of the world. I say this, and we've all been there. We've talked to people that are in their 70s and 80s that have seen and lived through things that we read about in our history books, and they will tell you that for the most part, when it was happening, it was just something that was happening. It was like 10 years later that it's seen as this big thing. I actually predict that the pandemic will not be forgotten anytime, if ever, because there has never been anything like this at all. There have been traumatic events that have impacted circumscribed populations. So sort of with the exception of the 12 odd countries that have reported no cases, 2 of which are North Korea and Turkmenistan, right? So you can't trust them. And the other ones are islands that most of us are unlikely to make it to. This is an experience, a traumatic one, that we can share with literally every single individual on the planet. There is no other example like this. So it's a fundamental shift. And I think recognizing that everyone's going through this together matters. So there is stress, there is depression, there is anxiety, even if it's not clinically significant or at the level at which it needs to be treated or medicated, it exists. So when someone says something about be kinder and gentler, that's not just cute advice. I think that is a therapeutic recommendation that if once a day something that could be an aggravation, you can step back like your older patients might and say, it's fine, let it go. I think that reduces the burden and that simplifies things. Insofar as technology goes, though, I think we're getting actually much more sophisticated in our understanding of not whether, but how and when to deploy it. The pendulum swung from being no telemedicine to everything telemedicine. But what we really need is that happy middle, sophisticated understanding of what works on telemedicine, what needs to be in person, how do you combine it? So new models of care, new models of communication and interaction that, maybe a first evaluation does need to be in person, but maybe ongoing maintenance care and psychotherapy can be telemedicine. If you're changing a medication, the reason for that change should be based on an in-person assessment, but monitoring and dose adjustments can be via telemedicine. So I expect that we're going to get far more sophisticated in understanding how to combine in-person and telecare. I think the second big thing that not the pandemic, but the digitization that came about as a result of the pandemic, I believe that this is going to create an even bigger technology wave around artificial intelligence. So I don't think any of us needs to worry about job security, that the AI is actually not that intelligent. It needs constant training and putting in context, and the robots are not in fact about to take over. But I think when you have the ability to do so much digitally, it's generating volumes of data. I think the process of harnessing those data and automating and reducing inefficiencies in clinical process, I think that is the opportunity. It can go horribly wrong. It needs regulation, it needs policy, it needs guidance. We've learned that the technology industry, bless them, cannot be relied upon to do this all by themselves. Clinicians and stakeholders need to have a voice. But I do believe that telemedicine is not even the tip of the iceberg. It's basically the spotting of the iceberg with the scope in the distance. The real change is only just begun.
Very important, I think, highlights to take away and to keep in mind as we move forward with the hopeful closure and ending of the pandemic. And I think an open, flexible, and a judicious mindset and use, along with the right blend of the human touch, is the right way to, I think, move ahead in a digitally growing world of medicine and healthcare, even for our elderly. I think the only thing that I would like to close with is the fact that I think when we speak about addressing geriatric mental health care or just geriatric healthcare in general, the ultimate aim and goal is to help our elderly become independent, live independently, and with dignity as well. And I think the COVID-19 pandemic has shifted our entire healthcare from patient-centered to being community-centered, which I think urges and invites all of us as, private, public healthcare systems, as NGOs, professionals, as well as community inclusively, to sort of come join hands and walk together so that we can ensure a better healthcare for each and everyone, like how Dr. Vahia was mentioning, and especially inclusive of our elderly as well. I think I want to take a quick moment to thank all our panelists, Dr. Murthy, Dr. Vaitheswaran, Dr. Vahia, for sharing such insightful comments and experiences with us throughout this panel. I hope it has been a fruitful session for all our attendees engaging with us today. And I think once again, on behalf of all of us, a big thanks to Asia Society India Center for organizing this conversation.